Let's talk about something every nurse needs to be ready for: altered level of consciousness. This is not just about someone feeling a little sleepy. This is about real neurological changes that signal something deeper and potentially dangerous is going on. Consciousness exists on a spectrum. On one end, we have patients who are fully alert, responsive, and oriented to person, place, and time. On the other end is coma, completely unresponsive, with no ability to follow commands and no purposeful reaction to external stimuli. Between those two extremes are several distinct levels that help us classify just how altered someone's neurological status is. When a patient has an altered level of consciousness, it means they are not oriented, they do not follow commands appropriately, or they require constant stimulation just to remain awake. This is not the same as being tired or drowsy. It is much more serious. If someone is in a coma, they are unarousable. You can clap, shout, or perform a sternal rub. They will not give any meaningful response. You may still see reflexes or even posturing, but there will be no purposeful movement. That is the key difference. There is also something called akinetic mutism. This condition is difficult to witness because the patient appears awake. Their eyes may be open, but they do not move, speak, or react in any voluntary way. They are alert on some level, but totally disengaged from their environment. Another state is known as persistent vegetative state. These patients do have sleep and wake cycles. You may see their eyes open and close, but there is no conscious awareness, no emotional response, and no interaction with their surroundings. They are not comatose, but they are not truly conscious either. There are two more terms that you need to know, both for exams and for clinical practice: minimally conscious state and locked-in syndrome. In a minimally conscious state, the patient shows occasional but consistent signs of awareness. They may follow a simple command one moment and fail to respond the next. The key difference is that those moments of awareness can be repeated. They are just inconsistent. Locked-in syndrome, on the other hand, is perhaps the most devastating. These patients are completely paralyzed. They cannot speak, they cannot move any part of their body, except they can still move their eyes vertically and they can blink. They are fully conscious, fully aware, and fully trapped inside their own body. These patients hear you, they understand you, and we must never assume they do not. Always talk to them. Always explain what is happening. They are in there. When it comes to assessing someone's neurological function, the most important clinical indicator is their level of responsiveness. If a patient who was once alert is now slow to respond or hard to wake, you are watching a neurological decline happen in real time. This is your biggest clue that something is wrong. Forget the scans and laboratory results for a moment. If someone's level of consciousness changes, you must take it seriously and act fast. Now let's talk about what causes an altered level of consciousness. It is not a diagnosis. It is a symptom of something else going wrong. Our job is to figure out what that is. There are three main categories of causes: neurologic, toxicologic, and metabolic. Neurologic causes include stroke, traumatic brain injury, seizures, or anything else that directly affects the structure or function of the brain. Toxicologic causes involve substances such as drug overdose, alcohol intoxication, or exposure to harmful toxins. Metabolic causes include things like liver failure, kidney failure, or diabetic ketoacidosis. If the body's chemistry is severely imbalanced, the brain is going to react to that. Let's go a little deeper. There are a few ways the brain can end up in an altered state. One mechanism is direct damage to the nerve cells in the brain. This could be caused by trauma, swelling, a lack of oxygen, or an infection. Another mechanism involves disruption in the brain's chemical messaging system. When neurotransmitters are out of balance or are not being received correctly, the entire system can start to misfire. A third possibility is structural damage to critical brain regions. The cerebellum is responsible for movement and coordination. The brainstem controls essential life functions like breathing, heart rate, and blood pressure. Damage to either of these areas can have life-threatening consequences. So, what does this all look like in real life? The earliest signs of altered consciousness are often subtle. You might see behavioral changes like restlessness, confusion, or increased anxiety. These are early red flags. If a family member says, "She is just not acting like herself," believe them. They know her baseline better than anyone. The pupils are also a key part of the assessment. Normally, pupils are equal in size, round in shape, and reactive to light. If the brain begins to deteriorate, the pupils may become sluggish, unequal, or fixed. A fixed, dilated pupil, especially if it is on one side only, is a late and ominous sign. If a patient is in a true coma, you will observe three main things: no eye opening in response to voice or even pain, no verbal response of any kind, and no voluntary movement. These are the bedside indicators that tell you the patient is deeply unresponsive and neurologically compromised. Now that we've talked about what an altered level of consciousness is and what causes it, let's dive into how we actually assess and diagnose it, both at the bedside and beyond. First things first, altered consciousness affects every system in the body. This is not just a neurological issue. It is a whole body issue. So even if you suspect a brain-related cause, you still need to perform a full head-to-toe assessment. You would be surprised how many valuable clues can show up in the skin, lungs, or abdomen that point you in the right direction. When it comes to the neurological exam, there are several areas you need to cover. Start with mental status. Can the patient follow commands? Do they respond appropriately to questions? Are they confused, agitated, or completely nonverbal? Then move on to the cranial nerves. This includes pupil size and reactivity to light, facial movement and symmetry, as well as protective reflexes like gag and cough. You will also want to check cerebellar function, which helps you evaluate balance and coordination. That might include observing for tremors or checking if they can touch their finger to their nose. Reflexes are another key piece, both the deep tendon reflexes and the plantar response, which can give you insight into upper motor neuron function. And don't skip the motor and sensory exam. You need to know whether the patient has strength and sensation throughout the body, or if there are deficits on one side or in certain limbs. Now let's talk about scoring. The most widely used tool to measure level of consciousness is the Glasgow Coma Scale. This scale breaks things down into three categories: eye-opening, verbal response, and motor response. A fully normal score is 15. The lowest possible score is 3, which indicates severe dysfunction of the brain, or possibly even brain death. If your patient's score on this scale is dropping, that is not just a number, it is a clinical emergency. It means the brain is losing function, and quickly. Here is a quick trick I love when evaluating patients. Look at the pupils. If a patient is in a coma and the pupils are abnormal, meaning they are fixed or dilated, you are likely dealing with a primary neurological issue, like a hemorrhage or a traumatic brain injury. But if the pupils are completely normal and the patient is still unresponsive, you should start thinking about metabolic or toxic causes. This includes things like overdose, liver failure, kidney failure, or sepsis. After you finish your bedside assessment, the next step is imaging and laboratory work. Usually, the first imaging test ordered is a computed tomography scan of the head. This is especially helpful when you are trying to rule out a brain bleed, stroke, tumor, or mass effect. If more detail is needed, or if you are investigating metabolic processes, your team might order a magnetic resonance imaging scan or a positron emission tomography scan. If you are worried about seizures or subtle electrical changes in the brain, an electroencephalogram can help detect both obvious and hidden seizure activity. Now let's go over the labs. These are absolutely critical. You need to look for causes like low blood sugar, abnormal sodium levels, and other metabolic disturbances. You will want to order a complete set that includes blood glucose, a full electrolyte panel, serum ammonia, liver function tests, kidney markers like blood urea, nitrogen, and creatinine, serum osmolality, calcium, and coagulation labs such as prothrombin time and partial thromboplastin time. If your patient has a history of diabetes, alcohol use, or altered nutrition, it is wise to add in serum ketones and a full alcohol and drug screening. Finally, arterial blood gases give you valuable information about how well the patient is oxygenating and whether there's a problem with acid-base balance, like respiratory or metabolic acidosis. So now you have your assessment and your labs. What comes next? The first medical priority in any patient with altered consciousness is airway. If they cannot protect their own airway, if they are not swallowing or managing secretions, you will need to secure it. This could involve placing an oral or nasal endotracheal tube, or even performing a tracheostomy if long-term support is expected. Once the airway is secured, ventilator support may be necessary to ensure proper oxygen and carbon dioxide exchange. The next priority is circulation. You want continuous monitoring of blood pressure and heart rate. The goal here is to maintain adequate cerebral perfusion, meaning you want enough oxygenated blood reaching the brain. If the brain is not getting what it needs, damage can worsen quickly. You will also need intravenous access, ideally 2 large bore lines to deliver fluids, medications, and respond to emergencies. Nutrition is another critical piece. Just because a patient is unconscious does not mean their body stops needing fuel. In fact, the body is often working even harder to repair damage. Begin nutritional support as early as possible. This may involve a nasogastric tube, an orogastric tube, or if the need is long-term, a percutaneous endoscopic gastrostomy tube. Finally, let's talk about targeted neurological care. You need to treat the underlying cause. If it is a stroke, you follow your stroke protocol. If it is an overdose, you administer the appropriate reversal agent. If there is cerebral edema or swelling, you may give mannitol or hypertonic saline. If there is seizure activity, use anticonvulsants to stabilize brain function. While you are focused on treating the primary issue, you must also stay ahead of complications. Things like aspiration pneumonia, pressure injuries, deep vein thrombosis, and infection can sneak up quickly in these vulnerable patients. When it comes to nursing assessment for patients with an altered level of consciousness, we start with 3 major areas: verbal response, alertness, and motor function. First, assess verbal response. You want to check for orientation to person, place, and time. Ask questions like, what day is it? Where are you right now? Who is the current president? And what is the next holiday coming up? These simple prompts give you a quick read on whether the patient is thinking clearly or showing signs of confusion. If the patient is intubated or has a tracheostomy and cannot speak, then you document that verbal response is unable to be assessed. Not absent, just not accessible under the circumstances. Next, observe the patient's alertness. Do they open their eyes on their own, or do they only respond when you call their name or apply a stimulus? Be sure to take into account any facial swelling or trauma that could make eye-opening difficult, so you do not misinterpret what you are seeing. Then we move into assessing motor response. Start by giving a simple command. Can the patient move their arm or leg when asked? Are the movements purposeful? If they are unresponsive, apply a painful stimulus. This could be nail bed pressure or a firm squeeze of the trapezius muscle. When interpreting motor responses, here is what you are looking for. If the patient withdraws from the pain and crosses the midline of the body, that is considered a purposeful movement. If their movements are random or aimless, that is non-purposeful. If you see posturing, you need to identify the type. Decorticate posturing, where the arms are flexed and the legs are extended, suggests damage above the brainstem. Decerebrate posturing, where the arms and legs are fully extended, indicates damage to the brainstem, and typically has a worse prognosis. If the patient is completely flaccid, with no muscle tone or reaction at all, that is the worst possible response. It is important to note that motor assessments are not valid if the patient is receiving neuromuscular blocking medications, because these drugs paralyze muscle movement and prevent any true motor response from being observed. Now let's talk about ongoing assessments. This is not a one-and-done situation. You must continuously monitor respiratory status, pupil size, and reactivity to light, reflexes, and the function of other body systems. That includes circulation, intake and output, gastrointestinal and urinary systems, and fluid balance. Any change in these areas could signal a change in neurologic status, and it is your job to catch it early. From a nursing diagnosis standpoint, especially for exams like the National Council Licensure Examination, you need to be fluent in the language of clinical reasoning. Common nursing diagnoses for patients with altered level of consciousness include impaired breathing related to neurologic dysfunction, risk for injury due to disorientation or confusion, and risk for fluid volume deficit due to inability to take anything by mouth. Other relevant diagnoses include risk for impaired nutrition related to inability to eat, impaired oral mucous membrane integrity from decreased oral intake, and risk for impaired skin integrity due to immobility. You should also consider risk for eye injury, especially if the patient has diminished corneal reflexes and cannot blink normally, which leaves the eyes exposed and vulnerable. Do not forget about impaired thermoregulation if the hypothalamus is affected. That can cause wild swings in body temperature. Impaired urinary elimination and bowel incontinence are also common because the brain may not be sending or receiving the correct signals. And for longer-term care, impaired ability to maintain personal health and hygiene is a major issue. Families are often overwhelmed as well, so include a diagnosis like interrupted family processes related to the sudden change in the patient's condition. In short, a patient with an altered level of consciousness is not just lying in bed. They are fighting a full-body battle, and our job as nurses is to assess, intervene, and advocate with everything we've got. Now that we've gone over the assessment, let's talk about complications, goals, and what nursing care really looks like for a patient with altered level of consciousness. This is where you move from just observing to actively protecting and intervening. First, understand the potential complications. Patients with altered consciousness are at risk for respiratory distress and even respiratory failure. Their airway reflexes are often diminished, which means they can't clear secretions or protect themselves from aspiration. If they vomit or have excessive saliva, they may inhale it, and that leads to pneumonia. Add in immobility, and now you're also worried about pressure injuries, venous thromboembolism like deep vein thrombosis or pulmonary embolism, and contractures from muscle stiffness and lack of movement. So what are the goals? Because this patient can't protect themselves, your nursing plan focuses on doing it for them. You're aiming to maintain normal breathing, prevent injuries, keep their fluids balanced, provide nutrition, protect their oral mucosa, maintain skin integrity, shield their eyes, regulate their temperature, support elimination, and involve the family in care. And most importantly, prevent those secondary complications from sneaking in while the patient is vulnerable. The primary nursing goal is to compensate for the loss of protective reflexes. You become their lifeline. That means protecting their airway, their skin, their eyes, and their dignity until their brain starts to come back online. Let's break down the core nursing interventions, starting with breathing. Airway protection is your top priority. These patients can lose airway tone, meaning their tongue or relaxed epiglottis can block the airway. They also can't effectively cough or swallow, so the risk of aspiration is high. What do? You start by elevating the head of the bed to 30 degrees. That small tilt helps reduce the risk of aspiration and improves lung expansion. Position the patient laterally or in a semi-prone position to help secretions drain. Keep suction equipment at the bedside and use it when needed to clear the posterior pharynx or upper trachea. Oral hygiene should be done regularly, not only to prevent infection, but to help with comfort. Listen to their lung sounds at least every 8 hours, and if they've got retained secretions, consider chest physiotherapy or postural drainage. And anytime you suction, make sure you pre-oxygenate before and after to avoid causing hypoxia. If your patient is intubated or has a tracheostomy, you have a few additional responsibilities. You must keep that endotracheal or trach tube patent. Perform oral care frequently, monitor arterial blood gases to evaluate oxygenation and carbon dioxide levels, and make sure ventilator settings are correct and continuously monitored. Next, let's talk about safety and injury prevention. Environmental safety is a major focus. Use padded side rails to prevent injury during movements or posturing. During the day, keep 2 rails up. At night, 3 rails are acceptable. But be careful. 4 side rails up is considered a restraint and requires a provider's order. Always check for environmental risks that could harm the patient. That includes restraints, check circulation frequently, dressings that are too tight, dislodged tubes or drains, wet or soiled bedding, or even foreign objects in the bed that could cause pressure injuries, like a remote, a syringe cap, or the patient's own foot against a hard surface. Preserve the patient's dignity. Always provide privacy, especially during care. Talk to the patient, even if they're unconscious. Auditory processing is sometimes preserved in comatose patients, and they may still hear you. Avoid saying anything you wouldn't want them to remember. No negative or hopeless comments. Be their advocate. They can't speak for themselves, so you must speak for them, both physically and emotionally. Now, one more safety consideration. What happens when they start waking up? If the patient is becoming more alert but confused or agitated, avoid physical restraints whenever possible. Try non-restrictive calming measures first. Gentle music, a quiet voice, dim lights. Physical restraints can actually worsen agitation or even raise intracranial pressure. But if it truly becomes necessary, you must obtain a written order from the provider before applying restraints. These patients are vulnerable, but not voiceless. Everything you do matters, and how you do it makes the difference between surviving and recovering.